We'll talk about shoulder. This is a fun chapter. I adore shoulder dislocations. One of the funnest things we can do in the ER. I love the fact that we're better at this than most orthopedists are because we do it all these days in the ER. Shoulder stuff is great. And there are other problems that are sort of related to the shoulder as well that we will talk about in this chapter as well. A couple of things overall. Shoulder dysfunction, shoulder problems. I'm actually, guys, I'm going to put a chair in here while you're doing your thing. So I'm going to bring a chair in at some point to demo. Anyway, 10% of the population has shoulder stuff at one point or another. Either things like impingement syndromes or acute injuries that are sort of one end of the spectrum, two even dislocations, which are another. But about 10%, 1 in 10, people have some sort of shoulder injury occur, shoulder problem occur. For the acute injury, our job really is to identify quickly what's wrong, get their pain controlled, and fix it, especially if it's a dislocation, as quickly as we can. The chronic things are a little tougher, and unfortunately the data is not fabulous on what really helps, particularly if you get to a grade 3 impingement syndrome with your shoulder as you get older. There's some pretty kind of discouraging data out there on that. A couple things on acute shoulder injuries. There are a couple things in the first section here that look at films. And they talk about all these fancy schmancy, anterior oblique, this and that and the other view. The key is what you really want is 3 views. You want 2 views AP of the shoulder with either internal external rotation or 2 different angles, and then you need to have either a transcapular Y or an axillary view. You need to have those to see not only the relationship of the glenoid to the humeral head, is there a dislocation, but if there are fractures, you need to actually have those views to see. And I'll tell you, some fractures, the weird fractures that you'll see of the glenoid or the labrum, can sometimes be very hard to see even on plain films, period. And rarely you'll need to default to CT scanning for really odd injuries. That's particularly in traumatized, majorly traumatized patients that you see that. It's very rare in just the dislocation kind of person. Now, how about films if you know it's a dislocation? How many of you don't get pre-reduction films in shoulder dislocations? Anybody have the nerve not to get them? Mezza. So when do you and when do you not?
If it's known and they've had it before and it's not particularly blunt trauma.
Perfect. Absolutely perfect. The reality is, in somebody who is a recurrent dislocator or has dislocated before, it looks like a dislocation, it smells like a dislocation. It wasn't it wasn't a huge trauma event, it was reaching. You don't need films, but you don't need films. There are a couple papers that look at this. If the patient, abstract number 4, says, if the patient has a clear deformity on exam, and if the patient has a lack of a fall, you can predict, yes, they have a dislocation. You can look at it, they're squared off, they didn't fall and have a direct traumatic event, they have a deformity on exam, you're done. You can predict it with incredible accuracy. And there's actually a couple abstracts that look at 5 and 7, look at this as well, that looked at a bunch of patients with potential shoulder dislocations. And they said to the doctors, is it dislocated? Is it not dislocated? Or do you just not know? In 69 patients, the doctor said, it's dislocated. And in 69 cases, the x-ray showed it was dislocated. In 9 cases, the doctor said, nah, it's not dislocated. And all 9, it was not dislocated. In the 19 where they weren't really sure, 16 of the 19 had an anterior shoulder dislocation. Some of them are hard. Sometimes people are heavy set. Sometimes they just have strange, it's not quite so squared off. There are different kinds of anterior dislocations. Some are harder to see on clinical exam. The bottom line is we can pretty much predict it. What are some of the reasons you might get, besides the fact it's trauma, just as far as why might you get a pre-reduction x-ray? What would be the impetus for that? Why would you get it? Rule out fracture. I would like to make an argument for you. If they've had direct major trauma, sure, you need this. But if it's somebody who has reached somewhere and just popped out their shoulder, even if it's the first episode, a non-traumatic injury, some people will argue, well, I'd like to know if there's a fracture there or not. A couple things about that. It's not going to change whether you actually relocate it or not. You're still going to do it, especially in not a major trauma injury. And the other thing is, do you want to know if the fracture's there before you relocate or after? If you don't do a pre-reduction film, you do just a post-reduction film and there's a fracture, you can say, well, of course it was there before I did anything. I didn't cause that. That was there beforehand. And actually, truly, the likelihood is it was. But you can argue pretty strongly against pre-reduction films if you're clinically sure of the diagnosis, there's not any major injury, and absolutely in the recurrence kind of episode where it just pops right out again. You don't need films in those. Post-reduction films, though, are probably useful. And there's a couple papers in here that look at this, but they basically are useful mainly to say, yes, it's back in all the way. You all have had cases where it clunks a little, it looks better, I'm just not so sure. We had 5 dislocations this week. I worked Monday, Tuesday, we had 5 dislocations in 2 days. Totally fun. I gave a lecture in rounds on Monday about shoulder dislocations when I started my shift. We had 5 dislocations in 2 days. The residents were like, yes, it was so much. And we tried different relocation techniques for each. It was totally fun, really fun. As far as the fractures and things are concerned, no worries, and it's clinically obvious. And we had 2 of them we weren't sure when they were back in, and one it was and one it wasn't, and we had to go try it again. So post-reduction films are useful. How do you all relocate shoulders? How many of you like the traction counter-traction technique? That's the I'm a brutane kind of guy. This is one you can do, by the way, if you're out and you fall down and you're in the middle of nowhere and you have a buddy. Okay, have your buddy basically lay you on the ground, put their foot in your armpit, grab your arm, and pull like crazy. That's the sort of layman's version of traction counter-traction. In the ER, we can certainly do that with putting sheets around people. And by the way, you don't need to have 2 people to do this. You need a really good locking gurney to do this, though. You can actually tie the patient to the gurney, under their shoulder to the gurney, and then you pull that direction. It is easier with 2 people, though, because that way you can actually make sure that nobody goes flying anywhere and the gurney stays put. Traction counter-traction works. I consider it a complete failure if I have to resort to traction counter-traction, however. I figure I have been defeated by that dislocation. If I have to resort to traction counter-traction, I'm always very disappointed. We had that one we couldn't get in this week that we had to resort to. The Coker technique, which is one of the original descriptions of how to relocate a shoulder, it's actually pretty dramatic, actually, which is supposed to be the true Coker technique, is to take the arm and externally rotate it until you meet resistance, and you will. Then you are supposed to sagittally elevate the arm and internally rotate. That's the original description of the Coker technique. The Coker and the traction counter-traction are the 2 techniques most commonly associated with us causing bad things, particularly fractures in osteoporotic people. They're the most torque that you'll put on that joint is with those 2 particular techniques. If you really want, I love this, I looked up an old technique that Perret did, get this. They used the ladder method in Ambrose Perret's time, and what they would do is they'd stand you on a stool, so my right shoulder's dislocated, they stand me on a stool a couple feet up, and stand me next to a ladder. What they do is they take my dislocated arm and drape it through the rung of a ladder, and then to make sure I don't go flopping around, they tie my legs together, and they tie my arm to my side. So the description of this, I love this. Let's see how he says it. He says, lest the patient hinder the operation and spoil all by laying a hand or setting a foot upon the ladder, bind the sound arm and both legs. Once the affected arm is placed through the rung of the ladder, pull away the stool and let the patient drop onto the shoulder and relocate. And I love this. As an added safety measure, it's recommended the patient not place his head through the rungs of the ladder prior to the stool removal. You might get an unexpected event with that one. Well, you can try that if you'd like. I don't have any ladders in the ER. But let me show you a couple techniques that I recommend. Come on up. I have a demo person here. Now, y'all have heard of the external rotation technique, most of us. It's a modified Milch technique, and I'll show you. You can sit here. You usually do this with the patient supine. What you do with the external rotation technique is this shoulder is dislocated. Okay? What you do with the external rotation technique is you chat. Okay, I'm just going to chat with her. I hang on here. We talk. Hi, how you doing? Visiting your kids? You having a good time? Oh, excellent. I'm glad you're having a good time here. Excellent. This is fabulous. And you gently lift it here. If you meet any resistance, you stop at any point in time. But that is the simplest. It's about an 80%, 85% success rate. Basically, all you're doing is keeping the arm to the side, against the side, externally rotating. If you get any spasm or grimacing or anything, stop. Keep going. Stop if they're grimace. Stop. Eventually, which you may just have it clunk right in here. You may have to lift the elbow away from the side. Sometimes you have to go even higher. But that's one technique to work. Another technique that can work if you have an older person. Say you have a osteoporotic 68-year-old woman who dislocates her shoulder. A great technique for that person is to have her keep her elbow bent. You tuck your forearm in her armpit. Okay? You hang on here. All I'm going to do is gently lift her shoulder up and out laterally while I pull down here gently. Success rate on the really muscular people on this is less, but as far as the trauma to the patient, it's almost 0. Success rate in older people is pretty good. There's a study in there that shows this technique, but this is one technique to do it as well. The scapular rotation technique, I'm going to turn you sideways. you go, face that way. How many of you have done scapular manipulation? This is awesome if you can get them early. If you get, we relocated one of the guys this week who literally walked in the door. He had dislocated like 20 minutes beforehand, walked into the emergency department, had a squared off shoulder. It had just happened, and we relocated him before we did anything. We just walked up and said, boop, pushed it, was done. Anterior dislocations, these are all anterior dislocations. What you do with this technique is preferably if they are supine, you have their arms straight up. But if they're sitting, you prop it on the table right in front of them. So take that little tray that they eat on and just prop it. It needs to be at 90 degrees to the body. You take the inferior aspect of the scapula, oh, she's nice and slender, so it's easy. You push it medially, but keep it down, and you stabilize the top of the scapular spine with your other hand. So I push this medially with my thumb. I stabilize the top of the scapula here. What I am doing is I am dropping her glenoid, her labrum, right down to her humerus, which has been dislocated. Can you feel it shift? Yeah. Yeah, you can actually, it's kind of uncomfortable if you're not dislocated, because you can feel your labrum start to come down. You can feel your whole glenoid come down in that technique. And then let's turn you forward one more time. There's another technique I really like. This one is totally fun because people don't believe it works. It's called the Cunningham Method. It's described in there in the last section of how to, by the way, these are all described in there. This is the Cunningham Method. What I like to do with this one, is what was described, is you're talking to the patient, and all you do is you have the patient put their hand on your elbow, and you put your hand inside their antecubital fossa. Okay? So we just sit and talk like this. What you do is, as you chat, you massage the trapezius, the deltoid, and the biceps. And as you chat, you go back, you massage the trapezius, the deltoid, and the biceps, gently traction down. What you're getting over is the muscle spasm. And it actually feels really good. And what you can do is you can combine this with other techniques. So if you're doing an external rotation technique and you're having a little trouble, have somebody else do the massage for you. It relaxes their muscles, and you don't feel a clunk. They just slide in. It's a remarkably effective technique. Thank you. This one's really fun, and it's actually very successful, particularly in a non-supramuscular person or somebody who's really nervous. Okay, all of these techniques work. They all work better with drugs. Okay? The reality is drugs are great. They all work better with drugs. So all of these, if you do procedural sedation, it's not really conscious sedation. The term is procedural sedation. That helps. You can also, what do you do though as far as sedation in somebody who has an alcohol level of 240 or who has 3 kids they have to go home and take care of and doesn't want to be snowed? What can you do for that person? You could do something quick, so something like propofol, but is there anything short of procedural sedation you can do? Massage. You could do massage. How about intra-articular lidocaine? Any of you guys ever done intra-articular lidocaine? We did 2 of the cases of the 5 we had this week with intra-articular lidocaine. 10 cc's, 1% lido. It's in here, actually, sort of the technique. But the one thing that's the nicest about intra-articular lidocaine is you cannot miss the joint. It is only joint. That's all you have is acromion and then joint. That's what you have sitting there. It's just posteriorly, laterally, anteriorly. You cannot miss that joint. Most people recommend the posterior approach because you can do it on somebody in or out. But any approach is fine. 10 cc's, 1%. Now, if you do this, the success rate of it is lower than with procedural sedation. Okay, it doesn't get you as much as with procedural sedation, but it is a great choice in somebody who's intoxicated and you're worried about giving them drugs. They're blitzed. Somebody needs to go home. They have to be able to drive. They have to be alert. The dislocation is acute. Okay, they just had it happen. Okay, the guy that we did with the scapular manipulation, we just gave a little shot intra-articularly, did scapular manipulation, he was done. It was easy. And let me see what else. That recent or recurrence. So those are the ones that it works the best in. If you do this, what I recommend you do, though, is to suck out any hematoma that might be in there, any blood that might be in there. This paper number 22 looks at this, but their recovery rate and their pain, as far as how they do during their pain of recovery, is significantly better if you suck out the blood. And that's actually true with any acute joint injury. You see people with an ACL tear, with a joint full of blood, take it out. and then go ahead and numb it up. But they do much better if you take the blood out first. So in a shoulder, since it's only joint, take your syringe that's empty, stick it in with an 18-gauge needle, suck out the blood you can, take that syringe off, put on the syringe, it's all sterile of course, put on the syringe with the 10 cc's of 1% Lido and inject it. You can also use bupivacaine. It does last longer. And a lot of people have defaulted to using the longer acting local anesthetics uniformly. That's absolutely fine to do, and probably actually I think a better practice if you want to be a little bit sort of more style points in your practice. Just make sure you make the doses appropriate to the patient size. 10 cc's of 1% Lido in virtually any adult-sized person is safe. You just have to do the right conversion factor for the bupivacaine. So lots of different ways to relocate. Pre-reduction films are probably not necessary unless there's a lot of trauma that you're concerned about, thrown from a car, fall, that kind of thing. Post-reduction films probably should be done. Intra-articular lidocaine is one way of doing it. Procedural sedation, though, is needed not infrequently in patients for this. Totally up to you which drug you use. So that's, and most of these dislocations are anterior shoulder dislocations. 95+% of dislocations are anterior shoulder dislocations. Where we get burned is in posterior shoulder dislocations. Abstract 15 is just a kind of like a paper that talks about this, but we had a case recently of a guy who had fallen, actually. He was, the classic description of a posterior dislocation person is the seizing person. You're the alcoholic who has a withdrawal seizure, the seizure patient who wakes up with shoulder pain. And mechanically, it is one mechanism to posterior dislocate, but you don't have to seize. People tend to think of somebody who hasn't seized as, oh, they can't have a posterior dislocation. And this guy had just fallen, had shoulder pain afterwards, had a normal x-ray, got his views, got it, basically what his views were, we got his films later, and an internal rotation view, external rotation view, and a transscapular Y view were the views that we got sort of in follow-up. He'd been seen at another hospital. He basically was told his shoulder was fine, was put in a sling, and came to see us months later, still in the sling. Really bad. I mean, at that point, he had adhesive capsulitis. That shoulder was going nowhere anyway. But in looking at his films on our films, and then in retrospect, looking at the films that he ended up getting and bringing with him to clinic, was he'd had a posterior dislocation day 1. The reason it's easy to miss, your shoulder is, it's actually, the shoulder joint, I am the most impressed of joints by the shoulder joint. Joints are awesome anyway, but that shoulder joint is amazing. Think of what you can do with your arm. It is incredible what you can do, but the reason when you do this, your humeral head stays down is because you have the rotator cuff holding everything down and in place. Okay, it has a cup it sits in, which is your glenoid fossa. That's bony. But the reason it stays there instead of slipping right out is you have a rotator cuff that sits, it's 4 muscles and tendons, ligaments that come over and hold it down. If you posteriorly dislocate, anterior dislocate, you've got all this space here. You've got your subcoracoid space, you've got all this space on your anterior chest. There's a lot of room to float this way. There is no place for it to go that way. What it gets tucked into is the teres minor and the infraspinatus muscles as they come around your scapula. If you posteriorly dislocate your shoulder, what usually happens is your lesser tuberosity pops back and gets stuck right behind, into the muscle area, right behind your scapula. It gets stuck. And most people, the seizure thing is you're tensing your muscle, and it pops it backwards. You can also get it with a fall this way as well. The reason the x-rays look okay is there's no place for it to slide behind because it's jamming against the muscles that are laying across the top of your scapula. They're attached to your scapula. So it sticks. If you look at films of people that have a posterior shoulder dislocation, the reason it looks normal is the humeral head and the glenoid look relatively normal, but it's actually here. Instead of here, it's here. But it can't slide way over here like an anterior can. It gets jammed right there. So that the relationship looks pretty normal on a film. What you're missing, though, and the clues to you that it's a posterior dislocation, one of them is when your lesser tuberosity gets stuck, you can no longer internally and externally rotate your shoulder. It's stuck. Okay, you have very little internal external rotation. So if you compare an internal and an external rotation view, they're going to look exactly the same because they cannot do that. They physically cannot do that. And no tech is going to come over and say, what they really care about is that they have 3 views. And they can show their boss they have 3 views. They're not going to come over and say, you know, that external view didn't move, but I took it anyway and called it external. They're not going to tell you that. So this and this looking the same on film basically tells you that they cannot move this. They can't do this if they do internal external rotation views. The other thing is this When you have the humerus in a normal glenoid, you have the humerus and the humeral head, it's in the cup. There's this area of overlap on film where the humeral head within the cup has an overlap within the glenoid fossa. It's this little sort of ellipse of overlap of bone, bone on bone, because it's sitting nicely in the cup. When you pop back behind, that overlap tends to disappear. So it still looks like it's sitting beautifully in the cup, except there's no overlap because it's jammed back here out of the cup. It's not in the cup anymore. The other thing that happens is when you have that internal rotation sticking, what you'll get is it'll look like the humeral head looks nice and round, for one thing, and it looks like it has a cyst in it. It looks like it has a hole in it, which is the greater tuberosity in the back. It has a little divot in it where the insertion of muscles occur, and it looks like a hole. When you look at films, your exam actually should tell you if it's a posterior dislocation. They can't do this. Physically cannot do it. You can't do it. You could try to, it won't go. You can't do it. It's stuck. That's one thing that helps you. The other thing is to actually look at that film carefully, make sure there's a good overlap within the glenoid, make sure that internal and external actually internally, externally rotate, make sure it doesn't look nice and round like a drumstick, and make sure there's no cyst-looking thing in there because that means it's not moving right. You're getting a posterior dislocation film. Those are our pitfalls, and I think we're just a little, as long as you're aware that that may be happening and something's funky with somebody's shoulder, just look at the films carefully and you won't miss that, and you won't miss it on exam. So that's posterior dislocations. And then complications. 26% of people with a shoulder dislocation have some sort of complication. That sort of starts in abstracts, sort of 23-ish. What the complications are, actually most commonly, is a brachial plexus injury of some sort, a nerve injury of some sort. Often axillary nerve gets involved. You may actually have a fracture, and the most common fracture is the Hill-Sachs deformity Bankart lesion kind of fracture, which is just an impaction fracture. It's not really a fracture so much as the coracoid sits on that humeral head, poking, and it causes an impaction fracture. It does make you more prone to redislocate later. It's worth noting because that person is more prone to redislocate later. But as far as fractures that we cause, it's rare. Now, the other thing to know is if they do have true bony fractures, a fragment kind of fracture, it is usually a lesser or greater or both tuberosity fracture. Think about what happens. That's where the insertions are of your rotator cuff and your deltoid. They insert on the greater and lesser tuberosity of your humerus for the most part. You take that humerus and you pull it 10 centimeters down with a dislocation into the anterior chest wall. Something may pull off. There tend to be avulsion fractures. I don't want you to ever hesitate trying to relocate a fracture if you have a lesser or a greater tuberosity fracture. What has happened is now those little pieces of bone are sitting up where the rotator cuff is hanging out waiting for the humerus to come back. So put it back. It is amazing how often it will slide right in and those two pieces, you won't even hardly ever see the fracture. They just line right up and do beautifully. Sometimes it'll get in your way, usually doesn't. It is not a contraindication to relocate if you have a greater or lesser tuberosity fracture off of there. So complications occur, just document things, and that's fine. Now, I love this one. Abstracts 25 and 26 say, okay, you did great. You diagnosed the dislocation, you didn't get the pre-film, you got the post-film, you did this great technique, you used whatever anesthesia or procedural sedation, fabulous, it's back in, now what? They did studies looking at what is the best anatomic for the rotator cuff and all of the anatomy proportionate to each other. What's the best way to immobilize a shoulder so that it heals with the least likelihood of redislocating and with the best range of motion? It's not this. We sling and swath all the time, right? We throw somebody in a sling, we kind of strap it to their body, don't move, you can take it out and rotate it a little bit every day so it doesn't get stiff, but oh my God, it'll slip right out again. It turns out that if you really want to maximize the healing and their function later, you're going to put them like this. Now, I would like to submit to you, first of all, there's no sling or immobilizer that does this. And in the paper that describes this, they concocted this sort of plaster, metal, strap it to the body thing that they put people in, which is hilarious. And then imagine trying to get around for 6 weeks like this. I mean, you'd be whapping into doors, you'd be hitting your spouse, it'd be impossible to do. The reality is, as far as practicality is concerned, immobilizing like this for somebody who has dislocated a shoulder is probably overkill, maybe better, but it's probably overkill. What is very interesting is that in these two papers, they look at the idea of not immobilizing at all. It turns out that that is probably a sound practice. If it's for pain control in the first couple of days, a sling is fine. They always need to do a little bit of motion every day so they don't get the adhesive capsulitis. But actually taking them out of a sling after a couple of days and letting them function dependent on discomfort is probably a fine way to go. And their outcomes may be better as far as redislocating or chronic pain. So something to think about. We actually, all of the extremity stuff we do in this particular course blows a lot of our standard practice out of the water. Okay, that's dislocations. Any questions on dislocations? Because I'm going to wrap a little bit with basically impingement syndromes and rotator cuff stuff. Okay, rotator cuff injuries or tendonitis or impingement syndromes are actually way more common than dislocations are. And I'm willing to bet that in this room, probably 4 or 5 of you have shoulder discomfort. And as we get older, the likelihood of a true rotator cuff problem or impingement syndrome skyrockets. Absolutely skyrockets. The background on this, if somebody gets a rotator cuff tendonitis, treatment is either nonsteroidals and or injections. Nonsteroidals are probably better. The impingement syndromes are the problem. The way you diagnose an impingement syndrome is people will tell you they have pain. Take this off. Move my microphone. To really test for an impingement syndrome, what you need to do, I get my coat off. Okay, off of there. Okay. Your rotator cuff, the way it works is you have a supraspinatus muscle that is what keeps your shoulder down when you do this. You have a subscapularis muscle that allows you to internally rotate your shoulder. It's the one that you test by doing this. Okay, that is the maximum internal rotation of my shoulder. That's subscapularis. The supraspinatus is what allows me to elevate my arm over what my deltoid is doing. My deltoid gets me to here. It's my supraspinatus that gets me to here. Okay, you can do this thumb up or thumb down. It's actually better to probably test it thumb up. And I also have a teres minor and a teres minor and the infraspinatus that are in the back as well. They're holding everything anteriorly. The most common injuries are supraspinatus injuries. That's the most common one that you'll get, and that's why people have pain when they raise their arm. And what an impingement syndrome is you test all 4 of the muscles, actually 3 motions that you really test, by pushing down on the acromion. By the way, impingement is where the space across the top of your humerus compared to the acromion above it gets narrowed or impinged, either just by getting narrowed over time or by being impinged with movement. And it really will affect your ability to move. And there are 3 impingement syndromes. Some of them are, by the way, anatomic. Some people are born with funky acromions. You know, the best acromion you can have is a nice flat one. If you have kind of a curvedy, pokey down one, you may just have an anatomic impingement syndrome from the beginning. You can get impingement syndromes from calcific tendonitis. Supraspinatus is the most common one for that. Because what you'll do is you'll be pushing down, you'll get them here, and they'll start to crunch and have pain as they start to lift their arm this way. Okay, that's an impingement syndrome. And you press down because what you're doing is you're taking my acromion and you're pushing it toward the humeral head and seeing if that causes the pain syndrome to occur. The symptoms that you get with this are the main thing you get is night pain. People cannot sleep on that side. They tend to limit their motion because it hurts, so they may not even notice they have limited that they reach up to the cupboard, or they do it with their other arm instead. But they may say, you know, I can't sleep on my right side. My shoulder kills me when I try to sleep on my right side. That is common for rotator cuff injuries that are causing an impingement syndrome. And if night pain, I've got it here. Supraspinatus weakness, night pain, and weakness on external rotation are the 3 biggest predictors of impingement syndrome and rotator cuff injuries. How you treat them depends on how bad they are. Sort of a grade 1 impingement syndrome is usually somebody who's able to function, but they get some pain when you range their shoulder. Grade 2 impingement syndrome is they cannot range their shoulder either actively or passively without agony. Grade 3, they have rest pain, night pain. Grade 1s are nonsteroidals or injections. Grades 2 are strengthening exercises and nonsteroidals and injections. And grade 3s may not be fixable at all, but they may be able to go to the OR and actually break up some of that problem in the shoulder by actually moving them, manipulating them under anesthesia. That ends up being kind of an ortho thing. So there's your deal on shoulders. Any question? Fun. I love shoulders. Totally love shoulders. They're the funnest thing. So satisfying. Yeah?
Scapular rotation. Do you use anesthesia before you do it?
Depends. If you can catch him early, like we did this guy the other day. We couldn't get him in the minute he walked in the door, but we did an intra-articular injection and then rotated him, and he was in no time. And he actually, He's like probably the quickest patient I've ever seen at Harbor. I mean, he walked in the door, we were kind of bored. And he was like, ooh, shoulder dislocation. Everybody like pounced on this poor guy. We did scapular manipulation, it wouldn't work, injected him, did it again, boom, it was in.
In McNamara's paper, it works about half the time without anything, and that's about my experience too. If you see someone in triage with it, it's the kind of thing that I like to try before you try anything else.
Yeah, it's nice, especially if you can get somebody out quick.
No yelling, no screaming.
Oh, yeah. It's awesome. They just get that funny like, ooh, look, when you feel your shoulder kind of going, ugh, and then it's in, it's done.